Hello, everyone. This is your asynchronous class for Anatomy and Physiology 3 in the spring of 24 semester at Pacific College of Health and Sciences. I'm Professor Adam Baritot, and I'm going to be taking you through the first half of our lecture regarding the respiratory system. We're going to dive right in. I will work efficiently. You're free to go back and watch this video as many times as you like, and do feel free to reach out to me if you have any questions. So, here is our lecture. Very good. Starting from an enlarged screen, we're going to start at the top and set to slideshow for everyone. Everybody should be able to see the lecture now. We're starting with the respiratory system. In this chapter, we're going to discuss the anatomy and physiology of the respiratory system, describe the events that cause inhalation, exhalation, and gas exchange, and explain how oxygen and carbon dioxide are transported in the blood. Spoiler alert, part of that is by red blood cells. Breathing and respiration is our kickoff here. Respiration is the exchange of gases between the atmosphere, blood, and the cells. We generally take in oxygen as our catalyst fuel for our body, and we will exhale carbon dioxide as our waste product. Carbon dioxide because oxygen provides a burning reaction, and the end product or waste product of a burning reaction is carbon. You may have heard some sci-fi channels call us carbon-based units. That is what they're talking about. The combination of three processes is required for respiration to occur. Number one, ventilation. That is the intake of the outer atmosphere, the intake of oxygen. Within our lungs, we will have pulmonary respiration, which is that initial exchange of gases. Oxygen coming into our bloodstream, carbon dioxide leaving our bloodstream. Within our body tissues, we have internal respiration, where the oxygen will leave our red blood cells and go to our tissues, our various cells throughout our body, and our bloodstream will pick up any waste products such as carbon dioxide. The cardiovascular system assists the respiratory system by transporting gases. The circulation of blood is at least in part to collect that oxygen and travel it around the body. Structurally, the components of the respiratory system are divided into two parts. We have an upper and a lower respiratory system. Functionally, those components are divided into two zones, a conducting zone and a respiratory zone. The upper respiratory system can be called a conducting zone, as it will draw the atmosphere into our body, into our throat, and down towards our lungs. Actual respiration occurs in the respiratory zone, which is in our alveoli within our lung tissue. So upper respiratory is generally conducting, lower respiratory is, in fact, respiratory. And there are some links for you to follow on your own time to study a little bit further. Taking a look at an active respiratory system, we have our apertures here at the top. Both our nose and our mouth can be used in function to respirate. The nose is preferable for a number of reasons we'll get to. We have our internal nasal cavity, which has various apparatus in it to spin air to keep it circulating so that we can filter out any impurities. Conducting from the nose to our throat is a area called the pharynx. Pharynx is that back of your mouth. Causes that gag reflex hanging out in the back of our mouth, leading down to our larynx, where our air will pass through, and down our trachea, where our trachea will divide into bronchioles, right and left main bronchi, and eventually into our lungs. We can see a formerly living creature right here with the same concept. The ribs are cut out of the way so that you can see these structures cleaner. We can also see some right subclavian. There's our brachiocephalic artery. There's our left subclavian artery. We don't have our left carotid. I don't see it. Very well. The upper respiratory system consists of the nose, pharynx, and other structures. The lower respiratory system consists of the larynx, trachea, bronchi, and the lungs. let's take a look at an overview of our upper respiratory system. We can see these areas here. We're just taking a look at stuff we already know about: palatine bone, oral cavity. There's our maxilla. But ultimately, we are looking at the nose. External areas of the nose, your nostrils, are sometimes called a nares. Within our nose, for those of you who have seen a child pick their nose before, that is the nasal vestibule inside our nostrils. As air enters this area, that air will be spun. So the tiny little hairs within our cilia can detect odorants, as well as the larger hairs will cycle out impurities. Those spinning areas are called nasal conchae. They spin the air as it travels through our nose. Up here we have the olfactory epithelium, which is where our olfactory nerve will contact and send its mitral cells into our nostrils so that it can pick up scents. Behind our conchae, we've got our meatas, superior, middle, and inferior, to match our conchae. Those are holes by which they send air down into our system. Internal nares, that's a little aperture in the back of the throat. Sometimes you can feel it. It's way in the back, and it is very uncomfortable. Nasopharynx. Nasopharynx is an aperture that may lead to, your eustachian tubes and into your ears. Nasopharynx is that root. That opening of the auditory tube there is specifically the tube to your ears. Nasopharynx is this region of your throat. The pharynx behind the nose. Behind our tongue and in the back of our throat, we have our oropharynx, or our oral pharynx, where our swallowing process will take place before we get to our epiglottis, which is right there. As we swallow, it cuts off the flow of air to our trachea, and when we are not swallowing, that tube is open so we are free to breathe. As we heard on the television show The Good Place, it's a terrible mistake to put your eating hole next to your breathing hole, and yet we have done so anyway. That railroad tie switch that opens one tube, closes up the digestive tube when breathing, or closes up the respiratory tube when swallowing, is the epiglottis. I think all of you knew that as well. And this lower portion of the pharynx is the laryngopharynx. Three sections, naso, oro, and laryngopharynx, make up our pharyngeal process at the back. Below the level of our epiglottis, we have our trachea. Again, if we think about television shows, we often see someone slicing into the trachea because someone can't breathe. The infamous tracheotomy. This is where our trachea is located. Very good. Some of you know about the uvula, which is a dangly bit in the back of the throat. Can assist to move things as we swallow. We also find our tonsils back there next to the uvula. Some of you may still have them. I am lacking mine. Now, inferior to the mandible and the hyoid bone, directly inferior to the hyoid bone, we have our larynx. Our larynx contains our vocal folds, a unique structure to human beings. No other creature has such evolved vocal folds as we do because we use them for communication. Our vocal folds are attached between our cricoid, next to our thyroid and cricoid cartilage. And our vocal folds are actually contained behind protective folds that rest on top of them, called false vocal cords. Underneath those are our true vocal cords. When we speak, our false vocal cords slide out of the way, and our true vocal cords will vibrate. Our true vocal folds are aligned over our breathing apparatus, anterior to posterior. Many people think of aligning these superior and inferior. Anterior to posterior across the tube is how they function. Very good. The cartilaginous framework of the nose. The external portion of the nose is made of cartilage, shortly, loose cartilage specifically, and is lined with mucous membranes. Mucous membranes are there to protect our internal structures, to protect our cells so they do not dry out, and prevent against infection. Mucous membrane, in this case, we are referring to boogers, or snot, if you prefer. Here we find our nasal bones as our cartilage will attach to it. Lateral septal major and minor alar cartilages and lateral septal nasal cartilages make up our nose. Dense fibrous connective tissue and adipose tissue give it its lovely shape. The bony framework of the nose is performed by the frontal, nasal, and maxillary bones. That's the bridge of your nose. The bridge of your nose and above. The bridge is nasal, maxillary makes up the cheekbones around it, and frontal bone is up near the upper dividing portion. If you are to break your nose, generally what we're talking about is the breaking or shifting of the nasal bones that make that up. The upper portion of our nose is called the root. The tip of our nose is called an apex. The bridge of your nose is where that nasal bone is. And the external nares is another word for your nostril. It's another look at that particular structure. Nasal conchae and meiotises. Like I said, we have these spinning areas here, these little spirals that spin the air as it enters your nose. The superior and middle conchae are part of the ethmoid bone. The inferior nasal conchae is a bone unto itself. Those of you who learned your 206 bones will know inferior nasal conchae because that is one of your skull bones. As the air enters into your respiratory system, those structures spin the air so that it can be greater purified as it heads into your lungs. Again, the root, superior attachment of the nose to the frontal bone, the apex, the tip of the nose, the bridge, the bony framework of the nose by the nasal bones, and the external nares, your nostril. Really simple image. I mentioned the pharynx again. The pharynx functions as a passageway for air and food, provides a resonating chamber for speech sounds, and houses the tonsils, which participate in immunological reactions against foreign invaders, if you still have them. They frequently do become infected and are occasionally surgically removed. Again, the regions of the pharynx, naso for behind the nose, oro for behind the mouth, and laryngo for behind the larynx. Very straightforward. The larynx, or the voice box, is a passageway that connects the pharynx and the trachea. As we pass through this passage, again, we see the hyoid bone creating the upper border of such a structure and protecting the epiglottis. We see the epiglottis, its leaf and its stem. Our thyroidal cartilage, also known as an Adam's apple, helps to protect the arytenoid cartilage behind. The arytenoids, you can see them here on this image here. The arytenoids look like tiny little fingers with fingernails on them. That is essentially what they are. You have two tiny little fingers in your throat, and those fingernails are attached to your vocal folds. As you talk higher, you're going to stretch those vocal cords out. When you talk lower, they stretch their vocal cords back. That's what our arytenoid cartilage is doing, moving our vocal folds. You'll also see cricoligaments and cricoids all around our thyroid gland. Thyroid gland rests in front of our voice, and it has been surmised, hey, the vibrating of your voice helps to keep everything nice and conducive through the area. Vibration tends to be a healing process for all of these structures. Another look. We see multiple different cartilages here. There's our arytenoid cartilage again, and you see how it attaches to our vocal folds. Thyroid cartilage hanging out in front of it, and the vestibular folds are false vocal cords resting on top. There's a little aperture between the two called the laryngeal sinus. See that all there. Another look at this area with our epiglottic cartilage. You can see our infraglottic cavity here where the epiglottis would be. There's our vocal folds again. And the aperture between there, the rima glottis, between our vocal folds, and above it, the rima vestibuli for the false vocal folds. There are a number of videos you can watch online where someone will send a stope into someone's throat while they're singing, and this can help you get a better idea of how these structures work, if such things fascinate you. The structures of your voice have their own particular muscles, the vocalis muscle, the lateral cricoarytenoid muscle, the sternohyoid muscle, the cricothyroid muscle. All these little tiny muscles are there to create fine motor control for your voice. All of these structures through here are innervated by the vagus nerve. So when you get nervous, your voice can sometimes waver because the vagus nerve is primarily a parasympathetic highway. Here we can see structures of vocal function. When the vocal folds are apart, this is usually done during inhalation. When the vocal folds come together, they vibrate together. This is done during exhalation. Some people can actually phonate with their voice during inhalation. I am told it feels uncomfortable. However, some of you might be able to do that. You can see how that particular cricoid cartilage moves those structures back and forth as it attaches to the arytenoid cartilage. Some people can do funny tricks with their vocal cords. Some people can make this cricoid cartilage bow slightly. When you bow your cricoid cartilage, you sound a bit like Goofy. A lot of our funny voices come from the bending and distorting of these structures. The trachea is the next tube along our pathway. The trachea extends from the larynx to the primary bronchi. Within our trachea, we have a number of useful little cells here. You can take a look here on this microscopic image on the side. You can see that we have some ciliated epithelial cells. Again, the body loves its tiny little hairs. Those ciliated cells act as part of a protection mechanism to prevent structures from getting stuck in our throat. You're also going to see goblet cells portrayed along the internal walls here. Those goblet cells are going to be producing mucus. Those goblet cells are there to specifically create lubrication inside our trachea. Goblet cells can be irritated over a period of time, and that can lead to further issues such as a chronic bronchitis further down our respiratory system. We're going to find more about goblet cells as we descend into the bronchi. The entirety of our trachea is surrounded by rings of hyaline cartilage. The windpipe, as it is called, is reinforced. It's not just a normal tube, otherwise we could squeeze it and you wouldn't be able to breathe. It is a reinforced tube because breathing is so vitally important for our structures. We can see the tracheal cartilage there. In between, we've got tiny little trachealis muscles, which in case those rings need to move closer or further away. This trachea leads us down to the bronchi at the superior border of the fifth thoracic vertebrae, 1, 2, 3, 4, 5. The trachea branches to a right primary bronchus that enters the right lung and a left primary bronchus that enters the left lung. Our lungs are asymmetrical, which we'll talk about shortly. There are 3 lobes on the right, 2 on the left. Why so asymmetrical? Because there's a heart in the way. As the bronchi separate, there are 2 main bronchi, which will shift into different lobes. As I mentioned, those are lobar bronchi. Those lobar bronchi will subdivide into segmental bronchi. and then ultimately into bronchioles, and then terminal bronchioles, which end in alveoli. Upon entering the lungs, the primary bronchi will divide to form smaller and smaller diameter branches. The terminal bronchioles are the end of the conducting zone. Here we see our airway branching off. Main and lobar and segmental bronchi will sometimes subdivide as many as 10 times. Our bronchioles and terminal bronchioles will subdivide 11 to 16 times. And then we get into our respiratory zone, 7 to 19 times for respiratory bronchioles, alveolar ducts, 20 to 22. And at the very end, those gaseous exchange places are alveolar sacs. Our airway branches subdivide 23 times down to end in our alveolar sacs. Lungs are paired organs in the thoracic cavity. Just like a lot of things in our body, we've got two sides, two lungs. But much like the rest of our body, our lungs are asymmetrical. Asymmetrical due to other structures being in the way. They are paired organs, 2 lobes on the left, 3 lobes on the right. Our body does this due to redundancy. If part of our lungs are not functioning, you've got plenty of other parts of lung that will pick up the slack in order to keep you functioning. The lungs are enclosed and protected by the pleural membrane. Pleural meaning referring to lungs. If the pleural area of the body becomes infected, it leads to diseases such as pleurisy. There are cancers related to the pleural sac and the pleural cavity, such as mesothelioma. The lining of the lung or the enclosure of the lung can become as fragile as the structures within. Lobes and fissures. Not loaves and fishes, lobes and fissures. Again, our lungs will extend into our apex. They will curl up underneath our first rib. The entirety of our lungs are protected by the entirety of our rib cage. We do have a pleural cavity and plenty of pleura extending down to ribs 8, 9, and 10. Left lung cozies up, usually ending at about the level of the 8th rib, and the same thing about the right lung. The subdivisions are what they are, but the lungs are relatively similar in shape and size. Slightly smaller on the left, but not as much as you'd think. Only about the size of a heart. Here are different fissures. On the right-hand side, we've got a horizontal fissure and an oblique fissure that subdivide the superior, middle, and inferior lobes. We have merely an oblique fissure on the left side, separating a superior and inferior lobe there. The bottom of our lungs is a base. The base is attached to our diaphragm, which as it draws down, creates an internal vacuum cavity. Our bodies become vacuums temporarily as we draw the atmosphere from the outside world into our body for gaseous exchange. When we look at the medial aspects of our lungs, we can see a little bulge in the middle called the hilum. The hilum has all of our apertures, our coronary arteries and coronary veins as they move in and out. You can see these other fissures from that angle as well. On the left lung, we see the cardiac notch where the heart resides. Those alveoli, we mentioned those before. When the conducting zones end at the terminal bronchioles, the respiratory zone begins. The respiratory zone terminates at the alveoli, the air sacs found within the lungs. That is where our magnificent, magnificent gaseous exchange happens. Alveoli are sac-like structures. You can see them here. These are some observations of alveoli. We can see them lining this lung lobule stain. You can see that we have little terminal bronchioles here, but we see blood vessels running to and from. There are arteries, blue in this image. There are veins, red in this image. Actually, we're at the capillary level, but arterial capillaries and venal capillaries surrounding this area where the gaseous exchange may occur. The area is surrounded by elastic connective tissue so that these alveolar sacs can expand and contract to allow for gaseous exchange. There are two types of alveolar cells, type 1 and type 2. Very good. The more numerous type 1 alveolars, or pulmonary epithelial cells, are simple squamous epithelial cells that form a nearly continuous lining with the alveolar wall. Let's find our type 1 cells. Type 1 cell, type 1 cell, type 1 cell. Very good. A type 2 cell, called a septal cell, are fewer in number and are found between type 1 alveolar cells. The thin type 1 alveolar cells are the main sites of gas exchange. So this big old type 1 cell, this is our gaseous exchange zone. Type 2 alveolar cells, rounded or cuboidal epithelial cells with free surfaces containing microvilli. Let's find a nice type 2 here. There's the type 2. There's type 2. Secrete alveolar fluid, which keep the surface between the cells and the air moist. Included in the alveolar fluid is surfactant. Surfactant is a complex mixture of phospholipids and lipoproteins. Surfactant lowers the surface tension of the alveolar fluid, which reduces the tendency of the alveoli to collapse and thus maintains their patency, or their ability to be springy. Also in this area, we're going to find some alveolar macrophages, sometimes called dust cells. These phagocytes remove fine dust particles and other debris from the alveolar spaces. Also present are fibroblasts that produce reticular and elastic fibers. Underlying the layer of type 1 alveolar cells is an elastic basement membrane. Ooh, there we see our basement membrane there beneath these structures. Outer surface of the alveoli, the lobules arteriole and venule, disperse into a network of blood capillaries that consist of a single layer of endothelial cells and basement membrane. The exchange of oxygen and carbon dioxide between these takes place by diffusion across the alveolar and capillary walls, which together form the respiratory membrane. You can see the diffusion going back and forth between these two structures, the type 1 alveolar cell and the capillary basement membrane across the capillary endothelium. Despite having several layers, the respiratory membrane is very thin, about 0.5 micrometers thick, about 1/16 the diameter of a red blood cell, to allow rapid diffusion of gases. It's been estimated that the lungs contain 300 million alveoli, providing an immense surface area of roughly 750 square feet, about the size of a racquetball court, inside your lungs. Respiratory membrane is consisting of layer of type 1 and type 2 alveolar cells, again, an epithelial basement membrane underlying the alveolar wall, a capillary basement membrane that is often fused to the epithelial basement membrane. They're stuck together to create ease, and the capillary endothelium. It is through those 0.5 micrometer layers that gases exchange. Blood will enter the lungs via the pulmonary arteries and pulmonary circulation and the bronchial arteries for systemic circulation. Pulmonary circulation is blood flowing through. Bronchial arteries are blood to feed the cells themselves. Blood exits the lungs via the pulmonary veins and the bronchial veins. Ventilation perfusion coupling. In all other body tissues, hypoxia causes dilation of blood vessels to increase blood flow. In the lungs, however, vasoconstriction in response to hypoxia diverts pulmonary blood from poorly ventilated areas of the lung to well-ventilated regions for more efficient gas exchange. This phenomenon is known as ventilation perfusion coupling. When your lungs aren't functioning well, more blood will go to the areas of the lungs that are functioning well. It's called ventilation perfusion coupling because perfusion, or blood flow, to each area of the lungs matches the extent of ventilation of the alveoli in that area. Throughout the discussion of respiratory organs, we gave examples of structures or secretions to help maintain the patency of the system so that air passageways are kept free of obstruction. These included bony and cartilaginous frameworks, skeletal shapes, the C-shaped rings of cartilage. All of these things are there to maintain the patency of respiration. Unfortunately, there are also some factors that can compromise, including crushing injuries to bone and cartilage, deficiency of surfactant, spasms of smooth muscle. Knowing the things that can affect the respiratory system are important to understand how to treat them. Here are breakdowns of the various structures that we discussed. In our nose, vestibule, respiratory organ, olfactory organ, whether or not they have cilia, which are hairs, or goblet cells that produce mucus. Cilia, hairs, goblet cells, mucus. Nasopharynx, oropharynx, and laryngopharynx. Nasopharynx produces goblet cells, oro and laryngeo don't. If you have phlegm in your mouth, it's either coming from your nose or up from your digestive or respiratory system. So when you're coughing up sputum, it is not coming from your throat specifically. Larynx, no above folds, yes below folds for goblet cells. Same thing for cilia. We want our vocal folds free and able to move without hairs or snot in the way. Trachea, then we enter into, again, cilia and goblet cell country. Our bronchi, we have goblet cells except down to the smaller bronchioles, where we start to have the beginnings of respiration. Terminal bronchioles, no cilia, no goblet cells. Respiratory and alveolar ducts, no cilia, no goblet cells. These are all passageways that conduct down. Alveoli need to be able to move freely. So once again, no cilia, no goblet cells, no fluid of any kind in the lungs, if possible, just the surfactant. If there is fluid in our lungs, that's going to lead to a more significant systemic illness, which we will talk about later. There are 3 steps involved in basic respiration. The nutshell of what is going to occur is we are going to change the pressure in our lungs back and forth. At stage 1, at rest, when the diaphragm is relaxed, alveolar pressure is equal to atmospheric pressure, and there's no airflow. When the pressure inside your body is equal to the pressure of the atmosphere outside, there's no movement of air. Air stays balanced. During it, intercostals will contract, expanding the chest cavity. Chest cavity expands and the alveolar pressure drops below atmospheric pressure. Air flows into the lungs in response to the pressure gradient, and the lung volume expands. During deep inhalation, the scalene and sternocleidomastoid muscles expand the chest further, thereby creating a greater drop in alveolar pressure. When the pressure inside our body is lower, air will fall into our body. You don't even need to inhale. You don't have to. All you have to do is move your diaphragm. If you get comfortable with it, you can do it without making noise. A lot of your breathing over the course of while you're listening to me has been without noise. During exhalation, the diaphragm relaxes and the external intercostals relax as well. The chest and lungs recoil, chest cavity contracts, and alveolar pressure increases above the atmospheric pressure. One of the muscles to do that is transverse abdominis. Air flows out of the lungs in response to the pressure gradient, and the lung volume decreases. They get smaller. During forced exhalations, the internal intercostals and abdominal muscles contract, thereby reducing the size of the chest cavity further and creating a greater increase in alveolar pressure, like a cough. That is our basic three-step process for respiration at a larger scale. In pulmonary ventilation, air flows between the atmosphere and the alveoli of the lungs because of alternating pressure differences, inhalation and exhalation. Inhalation, the pressure is less in our body and atmosphere flows in. Exhalation, the pressure is greater in our body than outside and atmosphere flows out. This is perpetrated by Boyle's law. Pressure changes that drive inhalation and exhalation are governed by this. Volume of a gas varies inversely with its pressure. So as you inhale, we see greater amount of pressure in there. We see 1 liter at 1 atmosphere. As you exhale, we've got half a liter at 2 atmospheres. That's why an increase in pressure will drive gases out. A reduction of pressure will drive gases in. We increase in volume of gas by reducing our pressure. That is the physics behind the movement of our breathing. Here is a graphic of the muscles that perpetrate that inhalation, exhalation. There's our diaphragm, our primary breather. We see our internal obliques and transverse abdominis and rectus abdominis. Transverse abdominis being the big one for exhalation. Internal intercostals will retract. External intercostals will allow us to expand. And for forced inhalation, we've got the sternocleidomastoid muscles and the scalenes. We can see the amount of movement in a normal inhalation and exhalation. In a full exhalation, sometimes that diaphragm can climb high enough to gently massage the underside of the heart. During inhalation, a larger inhalation, sometimes that movement of the diaphragm can massage your internal organs in the other direction. And we already have this slide. Other factors affecting pulmonary ventilation. Surface tension. Inward directly force in the alveoli must be able to overcome to expand the lungs during inspiration. So if the force of air is coming into the body, your internal structures need to be overcome. If your internal structures are rigid or your lungs are not flexible enough, you will not be able to draw in as much air. This sometimes occurs with people who have had damage to the insides of their lungs. Elastic recoil. This decreases the size of the alveoli during expiration, which allows for less surface tension and more air to come inside. And the third piece of that would be compliance, the ease with which the lungs and the thoracic wall may be expanded. Again, the more rigid these structures are, the less air you can take in and the less respiration you have. Breathing patterns and respiration movements. Got some fun ones here. Unia, again, silent P because we're Americans. Unia refers to normal, friendly, easy breathing. Unia is that normal breath as we would explain it. Apnea, some of you have heard of sleep apnea. That is an inability to breathe due to obstruction. Sometimes that's your tonsils, sometimes that's your uvula. For many different reasons that sleep apnea can occur. Sometimes there's a deviated septum within your nostrils, which makes that difficult. Dyspnea is a shortage of breath or an inability to draw a full breath. We find this associated with some respiratory diseases. Tachypnea. Tachypnea would be rapid breath associated with someone in a stressful situation or someone who is in aerobic activity, such as exercise. Costal breathing is shallow breathing, consisting of upward and downward movement of the chest due to contraction of the external costal muscles. Costal breathing is a labored breath, which may be used in some circumstances for particular gain, the usage of the playing of certain instruments. A pattern of deeper breathing or abdominal breathing is sometimes called diaphragmatic breathing, where the breath of the diaphragm draws down and creates a lot more breath inside your body's cavity. Modified breathing movements. These are associated with various types of breath where your body is using breathing movements to protect itself or express. Coughing, long, deep inhalation followed by a closure of the rima glottis, which results in a strong exhalation that pushes potential foreign bodies lodged in the larynx, trachea, or epiglottis out of your system. Sneezing, a spasmodic contraction of the muscles of exhalation that forcibly expels air through the nose and mouth. Stimulus may be an irritation of the nasal mucosa, or for some of you genetic folk, staring at the sun. Sighing is a long, drawn, and deep inhalation followed by a shorter but forceful exhalation. Either done for relaxation or to express displeasure. Yawning, a deep inhalation through a widely open mouth, producing an exaggerated depression of the mandible. It may be stimulated by drowsiness or someone else is yawning, but the precise cause is unknown. We love that. Sobbing versus crying. Sobbing is a series of convulsive inhalations followed by prolonged exhalation. The rima glottis closes earlier than normal after each inhalation, so only a little air enters the lungs with each exhalation. Crying is inhalation followed by many short convulsive exhalations, during which the rima glottis remains open and the vocal folds vibrate, accompanied by characteristic facial expressions and tears. Sobbing versus crying. Laughing is the same basic movements as crying, but the rhythm of the movements and the facial expressions differ. Laughing and crying are sometimes indistinguishable depending on your observation. It can be hard to tell from a recording, sometimes which is which. Hiccuping, spasmodic contraction of the diaphragm, followed by spasmodic closure of the rima glottis, producing a sharp sound on inhalation. It's usually the irritation of a sensory nerve of the gastrointestinal tract. There are a lot of different techniques for this. Boo! Sometimes people will scare you to try and write things. Honestly, a complete and full exhale, followed by a normal inhale and another complete and full exhale should reset you. Valsalva, I love this one. Forced exhalation in a closed rima glottis, which may occur during periods of straining while defecating. Maneuver pressurizing the middle ear. The mouth and nose are closed and air from the lungs is forced through the auditory tube into the middle ear. Go ahead and plug your nose, close your lips, and force air out of your ears. Employed by those snorkeling or scuba diving during descent to equalize the pressure of the ear with that environment. Sometimes occurs when you're flying as well. As we get older, we can see a decrease in vital capacity, the amount of air we can draw in. Blood oxygen levels tend to decrease as we get older. In my teens, I had a blood O of around 100%. Right now, my blood O is around 99 to 98%. I am in my mid to late 40s. Alveolar macrophage activity. We have less macrophages and they're less active as we get older, meaning that dust will irritate and stay irritating, increasing risks of infections. Ciliary action of the respiratory epithelia are also reduced, leading to more things getting caught in our respiratory system. Consequently, elderly people are more susceptible to pneumonia as a result, bronchitis and emphysema as a result, and other issues. lots of homeostatic imbalances of our lungs, as listed here. I will go through these relatively quickly and efficiently. Asthma is a situation where the respiratory organs, specifically the trachea and the larynx, are potentially very sensitive. And irritation to those areas can lead to a spasmodic reaction due to an overproduction of mucus, which can lead to a tachypnea, a rapid breathing, as the body tries to normalize its breath. There's plenty of oxygen, but you're unable to get rid of the carbon dioxide in your system, which leads to hyperventilation. Below it is chronic obstructive pulmonary disease, COPD. This is a combination of both chronic bronchitis and emphysema. Together, they make up the two branches of chronic obstructive pulmonary disease. It is ultimately terminal, and it is irreversible, but you can prolong your issues with it. Generally, this is caused by persistent and lifelong exposure to smoking, to smoke of some kind, usually cigarette smoke. We have a lung cancer. Lung cancer is incredibly popular. It's accounting for 160,000 deaths annually. It's very hard to track. It's usually not found until stage 3 or stage 4 as a result. And it is not something we traditionally screen for unless someone is high risk, i.e. they smoke. Pneumonia is an infection of the lungs. Usually that infection will produce fluid within the lungs, almost always mucosa, as a result of that infection. Folks with pneumonia are susceptible to related infections and are generally hospitalized when they have this condition. Tuberculosis is a bacterial infection featuring a waxy-coated bacteria. The body cannot fight off that bacteria, so it walls it off in a little bump called a tubercle. Generally, it lies dormant unless your immune system becomes compromised. Then once that occurs, the tubercle will open and all the nasty little tuberculotic bacteria will infest your system. Your body will try and create more tubercles, destroying more lung tissue, and it ultimately deteriorates your lungs. It is easy to treat with antibiotics. Usually one course of antibiotics cures tuberculosis. The common cold is listed next. There are literally hundreds of different types of common cold. They are viruses, and they have been with the human species for thousands and thousands of years. There are a lot of different variations of them. They range from merely annoying to SARS, severe acute respiratory syndromes. The granddaddy of those SARS variations is a little virus called COVID-19. I believe you are familiar with COVID. That is a form of the common cold. Pulmonary edema is swelling of the lungs. It's often related to issues with circulation elsewhere in the body. It arises frequently from increased permeability of the pulmonary capillaries or increased pressure in the pulmonary capillaries. It usually coincides with congestive heart failure, specifically right side congestive heart failure. Cystic fibrosis is a congenital disease where the body creates thick, viscous secretions of mucus. The lungs are specifically affected with cystic fibrosis, leading to more frequent and severe respiratory illnesses. Other parts of the body are also affected. Feel free to do a deeper dive on CF for more information. Listed here, asbestos-related diseases, we tend to look to mesothelioma for that one, which is a cancer of the pleural area. Generally, asbestos is not commonly used anymore in building, but people of my generation and older may have been exposed to asbestos. The more frequently you were exposed to it, the more likely mesothelioma may contract. Also on here is sudden infant death syndrome. It rarely occurs before 2 weeks or after 6 months of age. It peaks when, usually peaks around the age of 2 to 4 months. It's more common in premature infants, low birth weight babies, assigned male babies, babies of drug users or smokers. However, there may be an abnormality that associates with SIDS, but it's linked to hypoxia. Generally, this is one of the reasons they tell you to, when you put your baby in the crib, to have the baby lying face up. Cases of SIDS can be associated with the child lying face down. That being said, your child has to be susceptible to SIDS for SIDS to occur. Acute respiratory distress is a larger loop. It is a larger aspect where many of these things may come into effect, but it can also refer to asthma. It can refer to viral loads such as influenza as well. Acute respiratory distress might be someone unable to actually draw a breath for one reason or another. Allergies might be in play. Treatments may involve antihistamines. It may involve adrenaline. It may involve the aforementioned tracheotomies. All right, folks. That, my friends, is our lecture for today pertaining to Chapter 23. When I see you again next week, we will resume more looks at Chapter 23. That will lead us into week 9. And the following week, you will have your second unit exam. I will have some nice review stuff for us to play with next week as we finish up Chapter 23. If you have any questions, feel free to email me, reach out to me. Otherwise, thank you all for a lovely evening. I hope you enjoyed this lecture, and I will see you the following week. Be well, everyone. Take care. We'll see you soon.